where you could see the chest compressions are adequate. This is compressing the heart so that there is completely venous return and also the arterial supply. The red denotes the arteries, the blue denotes the venous. There is a clear cut. This is a high quality CPR. What is meant by high quality CPR? Having a depth of 2 inches. The chest needs to be compressed for 2 inches. You could see that. See. And 100 to 120 compressions per minute. It should be rhythmic. The energy with which first compression is done should be the 120th compression also should be with the same energy. So let us now see what is not a high quality CPR. So if you stop the like doing CPR in the middle, see where the blood will be as such. And after 5 minutes or 6 minutes, the blood gets clotted. If the blood gets clotted, see this is a low quality CPR. See he is not giving a good effort to put chest compression. See if you are not doing a high quality CPR, there won't be any blood supply to the brain or to the vital organs. Even to the heart also blood doesn't get supplied. So what happens if the blood doesn't get supplied, as madam said, less than 1 minute? Definitely it could be brain dead or essential vital organs get into the infarct, hypoxic injuries. This is a low quality CPR. At the same time, this is again high quality CPR. Whenever a low quality CPR is being done by anyone in your team, please tell them, please push hard, push fast, push in a rhythmic manner. At the same time, you should not do a very rapid CPR. You should not do very speedily. Even if you do it speedily, what happens? Why shouldn't you do CPR very speedily? You need to chest recoil is needed. Why? If the chest recoil happens, the heart gets inflated, the venous return comes into the heart. Or else, if the venous return doesn't come into the heart, you will be pushing a empty balloon kind of heart. So, why is this important? Organs, already we discussed these. So, organs die if they do not get enough blood and oxygen. Enough blood means compressions, chest compressions. Enough oxygen means oxygenation. Oxygenation in BLS is being given by AMBU. Okay? And your heart pumps these supplies to your organs. If your organs suffocate, automatically the person dies. So, what are the indications? As I earlier mentioned, the indications are the patient should be unconscious, and then the patient needs to be pulseless. If the C is for circulation, C is for chest compressions, B is for breathing. You know how we assess a patient: A, B, C, airway, breathing, circulation, disability. Airway means whether the airway is patent or not. Breathing, whether the patient is breathing or not. Circulation means whether the person is having BP or pulse, whether the heart is beating or not. If there is no C, you have to go for chest compressions. If there is no B, you have to give rescue breaths. Okay? How to do CPR? Step-by-step instructions. So, initially ABC used to be there, even now also we follow ABC. ABC is only for conscious patients. If a patient comes to your OPD, if the patient we assess the patient through his airway, breathing, circulation, and the patient is sent for investigations, the patient went for canteen or someplace, and if he suddenly falls down in a restroom or in a canteen, then automatically get into CNE. If you see an unconscious patient, first go and check for his consciousness. We need to tap the patient and ask him whether he is awake or not, and then you need to check for pulse, and then look for the breathing of the patient. Look for pulse and then look for breathing of the patient. Okay? That is the reason ABC has been changed into CAB. This happened in and around 2010. From 2010 guidelines onwards, they changed it to CAB. CAB means compressions, airway, breathing. Okay? Or circulation, airway, breathing. So this is the basic, adult basic life support algorithm. This is very important. If you want, I'll be sharing this to you over mail also. This first we need to verify the scene safety. If the patient falls in a canteen or in a bathroom, automatically you need to pull the patient aside. You can't do it in a wet floor. Similarly, in out of hospital, the patient falls in the middle of a road, or the patient falls near a pond. If the patient gets drowned in a pond, please make sure the scene is safer. Scene is safer. Scene is safer means it includes our safety also. So we need to check whether the scene is empty or not. Then we will check for the responsiveness of the patient, whether patient is responding or not. If the patient is not responding, we need to check for the pulse, jugular pulse. This is adjacent to the trachea, the notch adjacent to the trachea. And then we have to activate the emergency response system. In US they call as emergency response system. In India we call as the code blue team. Okay, so we need to call to the code blue team or the nearest available consultant. And then we will be if it is happening outside in a shopping mall or anywhere in metro cities or tier 2 cities or any shopping malls, it has been mandatory in airports. It became mandatory that they need to have a AED installed. If an AED is installed available, then only we need to they are giving permissions. So automated external defibrillator will be there, and that is very helpful. I'll show you how it is helpful. So we need to shout for help. If we are alone, please ask for help. Please call someone for help so that we will be doing CPR until the help comes and the other person will be calling the ambulance. Why all these need to be done? Why all these need to be followed? Why do we need to call for help? We only can call the ambulance. We only can do this. We only can do everything now.
Save time.
Just to minimize the interruptions and just to make the person help come faster. That's it. So there are three scenarios. The first scenario is normal breathing and has pulse. I told you the first statement. This patient is admitted in our ward. The patient started sleeping and the patient is not waking up. Patient is having pulse. Patient is able to breathe out. Then, as earlier sir and madam mentioned, we need to check for sugars. GRBS. What is meant by GRBS? G for S means sugar, na? Again G for glucose, how will it happen? Generalized random blood sugar, GRBS. So we need to check for GRBS, means with the glucometer, whatever we have, we need to check for GRBS, and then if it is anything, we have to check accordingly. If the person is able to breathe and if the person is having pulse, please check every 2 minutes. Maybe the patient is losing the pulse, maybe the patient is losing the ability to breathe. So we need to check for every 2 minutes, reassess the patient. Every 2 minutes, please reassess the patient because we don't have an inbuilt monitor, we don't have anything in such kind of setups. And the second scenario is no normal breathing and has pulse. This one. No normal breathing and patient is having pulse. If the pulse is there is no need to give compressions. So if the pulse, as there is pulse, there is C, there is no need to give C. But we need to go for breathing, rescue breaths. How do we give rescue breaths? 1 in 6 seconds. Each rescue breath needs to be given in 1 in every 6 seconds. So 5 to 6 seconds, about 10 to 12 breaths per minute, but it is 12 breaths, let us consider. How do you say 6 seconds? Do we calculate like that? So what generally we do in ICUs or ER or in a transportation gets transported is, we do AMBO by giving 1 breath in 6 seconds. We give 1 breath, follow in every 6 seconds. How do we calculate 6 seconds? 1 in 1000, 1 in 2000, 1 in 3000, 1 in 4000, 1 in 5000. No need to speak out. You can put it inside. If you speak out, we'll get dehydrated. We'll feel thirst. We want to go and drink water. We lose interest on the patient. And there will be more interruptions. So calculate it inside. 1 in 1000, 1 in 2000, 1 in 3000, 1 in 4000, 1 in 5000. So if you calculate that, you can calculate or you can check. It comes exactly 6 seconds. So in that way, you need to calculate in your mind, even when the patient is on AMBO or if the patient is on a brain circuit. We calculate in that manner. Even the ventilator also gives in that way. Ventilator gives on that way only. So the third scenario, no breathing and only gasping, no pulse. If this patient is having no B and no C, no breathing and no circulation, what do we do? No B and no C. Automatically, first what we do? There's no pulse, patient is not breathing. What will be doing? We start CPR. Immediately we start CPR. We start CPR and then 30 compressions should be given followed by 2 rescue breaths. Each person should be giving 5 sets. 1 cycle of CPR is equal to 5 sets of 30:2. After that, if 2 rescuers are there, please swap. The person who has given the C should go into the head end to give the breaths, rescue breaths, because the person will get exhausted. You may ask why exactly 30, why exactly 2? It is just with multiple meta-analysis. Since 1971, I guess, they started all this CPR program worldwide, and then all this meta-analysis, they have concluded all these new methods. Okay, begins cycles of 30 compressions and 2 breaths. And if a AED is available or a defibrillator is available, please attach the AED or a defibrillator available. AED and the AED is one of the smart device which has been since long time, and many people even do not know how to use it. But there's nothing we know to know use it. It only tells everything. Just you need to place the pads on the chest, and it will tell you everything. Chest compressions. How do we do chest compressions? Push hard, at least 2 inches or 5 centimeters, but not more than 2.4 inches or 6 centimeters. Why? Chest trauma. If you push more than 6 centimeters, unless and if the person is very obese or hefty, it will cause chest trauma. Push faster, at least 100 to 120 compressions per minute. 30 compressions should take you not more than 15 to 18 seconds. If you do in a rhythmic way, and make sure that you do a CPR by putting your shoulders just above the patient. Why? The pressure should be exerted from the shoulder, not from the elbow. If you exert from the elbow, your biceps and triceps get tired. Easily you will get into fatigue. If it comes rightly from the shoulder joint, it would be something different. Right? The entire body center of gravity will be shifted onto the patient, and we can easily give the compressions. That is the only secret in that. So, allowing for complete chest recoil after each compression. Please make sure that chest recoil is happening. If the chest recoil is not happening, if you do like this, the heart won't get filled, and then we cannot do any further pumping of blood. So, minimizing interruptions to chest compressions. Please minimize the interruptions. As I mentioned, the interruption should be less than 10 seconds. Okay? Avoid excessive ventilation. Why? What is meant by excessive ventilation? Instead of 2 respiratories, you may think, okay, if I give 3 respiratories, patient will be getting more oxygen. If you give more ventilation, what happens? Yes? Right? So what if we give oxygen like this? I give an oxygen to the patient like this, what happens? If I give oxygen to the patient like this, let us assume the patient is on the flat surface. What will happen? The air goes into 2 tubes, esophagus and trachea. If it goes into trachea, okay, well and good. As you mentioned, maybe a third rescue breath will give more oxygen into the patient. What if it goes into esophagus? What if the patient had a full biryani and then collapsed? Aspiration, regurgitation, everything comes out. It will cause more harm. It will induce more harm rather than helping the patient. If once the airway gets obstructed, whatever you do in the CPR, nothing can be helped unless and if we go with the advanced airway or we go with a valve, bronchoalveolar lavage. So chest compressions, as I mentioned, it should be 2 inches, not more than 2.4 inches, and it should be 100 to 120 per minute. So where to compress the chest? We need to compress over the center of the chest. Again, why? Mannequin studies. They did it on the left side, they did it on the right side of dextrocardiacs, and it caused rib fractures. Further into blunt trauma or sharp injury of the chest, causing more hemothorax or pneumothorax. That is the reason. Sternum. Of course, if we do even in the sternum also, there are fractures happening. So still, sternum is the hardest part on the chest, which can take more amount of pressure. So the compressions are more effective only on the sternum, where exactly center of the chest, joining the nipple line. So place the heel this is the thenar hypothenar eminence. You need to place this heel, the dominant hand.
So I need to move it to the center.
Yes, sure. So place the heel, the dominant of dominant hand on the center of the chest over the sternum, and then place your other hand, and either you can lace the fingers or you can fold it as per your comfort, and you need to go straight. The shoulder should be exactly perpendicular to the horizontal like level of the patient. And how you give like this. The pressure should be coming from this. The pressure should not be coming from the elbows. If you give the pressure from the elbow, you will get fatigue so easily. So place your other hand on top and lace your fingers together. So keep your arms straight with your shoulders directly above your hands. We need to keep the arms straight. The shoulder should be above the patient because we need to exert more pressure with less efforts. Allow the chest to come like forth. Next. Yeah. Allow the chest to recoil. When you give a compression, please make sure that it should be completely recoiled. If you do not recoil, if you put like this, if you give pumping, you are just pumping a empty balloon. You make sure that the chest gets recoiled, and then you need to give a compression completely. Then only the heart gets filled, and then you can give further. If you give a one compression, the heart gets emptied almost 70%. Continue 30 compressions at a rate of 100 to 120 per minute. So deliver 2 breaths. So this is the bag valve. So how many of you know this? Ambu. So what is this? There will be a valve, a fish mouth valve will be there. What is need for fish mouth valve?
One way entry.
Only one way. It won't re-enter, it won't take back the exhaled gas. So that is the advantage with Ambu. And second thing, this is the reservoir. Even if the oxygen line gets disconnected all of a sudden, this would be having almost 15 to 30 liters of oxygen. This will help us almost for 1 to 2 minutes. Unless that if the patient is on very high flow oxygen. So you need to give 2 rescue breaths. And continue chest compressions and repeat cycle 5 times. That's exactly right. 5 times. 5 cycles, and then this should take approximately 2 minutes.
If bamboo is not there, how do you open?
Yes. If Ambu is not there, earlier we used to do this mouth-to-mouth breathing or with a barrier device. Generally, all the technicians or all the doctors in and around, or most of the doctors in Western countries, they have this barrier device as one of the first aid kit. So in Dubai, in other companies also, in luxury cars also, we'll be seeing this barrier device. They put a barrier device also. So barrier device is just to make sure that we won't be having a complete physical in-person contact, so that we cannot catch any communicable diseases from the patient. But after the COVID scenario has come, mouth-to-mouth breathing has been drastically reduced because of much more awareness, much more consciousness with respect to upper airway or lower airway respiratory infections. So now, what we need to do? Check for a pulse. After 2 minutes, we have to check for a pulse. If there is a pulse, stop chest compressions. Means if there is C, stop C. If there is circulation, stop compressions. That's what I meant. If there is no pulse, then please continue chest compressions. If you are there, please continue. If any second person is there, I ask him to come into the chest compressions and I will take the headache. Why? So that we will be exchanging, and the 2 minutes will be given to me as a rustic period so that I can regain the energy. Whatever ADP or ATPs are being consumed, they will be back with the ATP. Next. Continue resuscitation until the victim shows signs of life, a qualified help, the code blue team comes, or we get exhausted. If we get exhausted, no one will be there to do CPR to us. That's a fact. So this is the recovery position. If the person is having any pulse, if the person gains pulse and the patient started breathing, we need to place the patient on the recovery position. Why recovery position?
Keep open the airways
To keep open the airway and to prevent the secretions to get aspirated. So that is the reason. And what is meant by recovery position? Turning the patient on either left lateral or right lateral side. That is recovery position. And this is how do we resuscitate in a pregnant woman. We need to do CPR in a pregnant woman. How we do? We do the same way CPR. Just what we need, the only thing what we need to make sure is, please push the uterus, the gestation to the left lateral side. So that why
IBC compression.
the big vessels which are running along the spine are a bit right lateral, so that they won't get compressed. If you push the uterus towards one side, it will be helpful. Okay. Now pediatric. I'll be just discussing the changes with respect to adults. So in pediatric neonatal, how we do the check the pulse? How we check the pulse? Where do we check the pulse?
Femoral.
It was mentioned brachial or femoral. Why not jugular? Sir, you said jugular for adult. Why not in pediatric? Why are you showing differentiation between adult and pediatric? Even doesn't the children have jugular? Then why can't I check on the jugular? It is much easier for me now. Jugular is much more prominent than brachial. Na? Why in jugular?
It can further decrease. It can
Yes, sir.
decrease.
Short neck. It is so short, not this mannequin. The real babies are so short that even our little finger will make sure that it won't be palpating the jugular, because we are not palpating on the neck, we are palpating into the groove. If we palpate into the groove, automatically our little finger is also not sufficient. Again, you have to call one more child to check it. A 6-year-old child should come to check for the pulse in the jugular. That is the reason they opted for brachial or femoral. Generally, we go with the brachial. Brachial is the best one rather than the femoral. So how we do? In CPR in children will be on two types. One is either with a one hand or with a two finger technique. In adolescent people or people with a very lean body, we will do CPR with only one hand. Why? If we do with two hands, it causes chest trauma, barotrauma. If we do with a one hand, like two finger technique or thumb encircling technique. Two finger technique means we need to push the dominant hand's two fingers on the chest. Like this. So we'll be pushing like this. This is the way we do a two finger technique. For two finger technique, there's no need of having the shoulder straight, everything. If possible, you may do it. Or the second one is thumb encircling technique. You need to encircle the baby. You need to encircle the baby with your thumbs, and you need to approximate the thumbs over the chest, over the sternum, and then you need to give the compression. How many compressions? 30:2. Well, there comes the difference. Two rescuer, two thumb encircling technique. This is a two rescuer, two thumb encircling technique. If one person is there, we go with the two finger technique. If two rescuers are there, then we go with the thumb encircling technique. This is what they have written. But I find thumb encircling technique will be a bit easier, and also the baby gets catch and stabilized. If you do a two finger technique, we can zip the baby. So always make sure that when a two finger technique is done, put a pillow on the other side of the baby, both the sides, so that baby won't be moved. So what is the depth? 1/3 of the AP diameter of the chest. It is something around 5 centimeters in adolescent people. So how we do? And one more big difference is this. Single rescuer 30:2. Two rescuers 15:2. Why? Okay, 30:2 is there. There's no confusion. Let us follow 30:2 even in children also. Why? Why again you are confusing me with 15:2? Why? Children require more amount of oxygen because they are having developing brain, developing organs. So the more amount of oxygen utilization will be there in children. So that is the reason we require equal amount of compressions with more amount of oxygen. That is the reason we do 15:2. You may ask 15:2, what if the baby might have drank the milk? The baby can vomit. Of course, the baby can vomit, but we cannot let the baby go into hypoxic injury. If the hypoxic injury happens to a 6 months old baby, though the baby was born with normal milestones till 6 months, the baby will become mentally retarded. So that will be a complete disaster to the entire family. So oxygenation is that much important when you compare when we equate with the compressions. So foreign body, this is single rescuer 30 is to 2, two rescuers 15 is to 2. Please remember this. And at least one third of the anterior posterior diameter in approximately 5 centimeters in a child. Foreign body airway obstruction. So what is the foreign body airway
Till
obstruction?
what age?
Sorry,
That principle is till what age?
16 years.
To 16 years.
Generally, we follow till 12 years. They documented it too. But because of the new anatomy in this generation, from 2010 onwards, the new anatomy, the children are having very good physique compared, and the early development are there in the children because of the additional nutrients, additional input of the add-on powders and everything. So what we are considering is depending upon the child. So 15 to 16 years, we consider them as pediatric. But I consider till 12 years, we do the 15 is to 2, 30 is to 2. We get many neonatal and adolescent persons who have trauma. And trauma is completely different scale, sir. There, 15 is to 2, 30 is to 2, we forget everything. If any trauma case comes, like a child, recently also we got a child fall from something around 20 feet, immediately and skull was open. What we have done is immediately I have done a airway securing, and immediately we have put a needle, large bore needle into the chest. I do not know whether the baby is having, but the baby is not breathing. So pupils are normal, luckily. Just there is a compression, we do not know initially. So immediately what I have done, I have intubated the baby and I have put a needle into the baby's chest, thinking that it could be a pneumo or hemothorax. Luckily there was a pneumothorax. And then when we intubated also, everything was there. Then when we see there was a bleed inside, an extradural hemorrhage, which was operated and the baby became normal. That was very advanced. It's into ATLS. Even I did not gain, like I had gained that kind of confidence only after 2 to 3 years of my experience. After I have become an ATLS provider. So in babies it is completely different style. I'm specialized in pediatric emergency medicine. So we do get babies. 15 is to 30 is to 2 is only for basic life support. But when it comes to advanced cardiac life support, what we do is we intubate the baby, we connect to the ventilator. I don't even touch the ambulance. Because if I put a ventilator, I'll be getting one more man's house. So that I can take them into for compressions, or I can take them to send for full, ask them for blood or some kind of investigation. Some kind of help is needed. Because hospital is the only place where, even though we recruit 100 people, we are in requirement of 100 more. Foreign body area obstruction. What is it? Complete